Hello, welcome to this mini-series from the MDTea Podcast team, covering some of the more common issues encountered when working with older adults. Each session is structured around a clinical question, and our aim is to help you approach these issues like a geriatrician. The best part, they're all under 10 minutes long. I'm Ian Wilkinson, I'm a geriatrician down from Surrey in Sussex, and working with me today are Joe Preston.
Hello.
And Alice O'Connor.
Hello.
Members of the MDTea team. This session is going to cover how to assess a patient who has fallen.
So Mrs. Topple has come in with her third fall this month. How do we get her home safely? It's not really clear why she's been falling, so we need to find out why.
So falling over is a very common reason for older people to come into hospital, and it's often indicative of a more complex underlying problem. Unfortunately, we sometimes end up discharging these people before we've had a chance to figure out what the problem actually is, or to arrange the appropriate follow-up. But when assessing somebody who's fallen, there are 5 things that you should ask when taking a fall's history.
Number 1, did they pass out? Is there any loss of consciousness? That normally indicates one of the more sinister reasons for falling, such as cardiac arrhythmia or a seizure. Number 2, do they remember the fall? If not, did someone witness it? Are you able to talk to them? Try to get an idea of how suddenly it happened, what they looked like before and just after. And if they did lose consciousness, try and work out for how long and then how quickly did they recover afterwards.
Number 3, as well as looking for visible injuries, ask if they've got pain anywhere and whether they were able to get themselves up after the fall. Depending on their level of support and physical function, injuries can have a really significant impact on their recovery time and where they can be discharged to. Or ask for how long they were on the floor. If you're not sure, you may be able to get an idea from asking if they remember what they were doing last and the time that help arrived. This will tell you the maximum time that they were on the floor for. If someone has spent several hours on the floor, or got stuck in the same position, they'll be at a high risk of rhabdomyolysis, there'll be a risk of pressure damage and dehydration. And they may have missed some important medications.
Number 5, have they previously been investigated for falls if they've had falls before? As with many things, you don't want to spend ages trying to organise an investigation or clinic appointment only to find that it was done 3 months ago.
So when thinking about falls, you can think about falls being syncopal or non-syncopal. So within the falls caused by syncope, some people may have a brief loss of consciousness, which is more indicative of a cardiogenic cause, such as an arrhythmia, or an orthostatic cause, such as postural hypertension. Or they may have had a longer loss of consciousness, more indicative of a neurogenic cause, such as a seizure or something. If you flip over, then thinking about non-syncopal causes of falls, they can be due to extrinsic factors or intrinsic factors. So extrinsic factors would be something like being hit by a car. It's quite normal to fall over if you're hit by a car. Intrinsic factors are stuff that's much more related internally to your physiology. So if you've developed Parkinson's disease and some cognitive impairment, your risk awareness may be down, your gait might not be normal, and therefore your risk of falling increases. As we get older, there is also an interaction between these extrinsic and intrinsic factors. So a younger person may slip on some ice. That would be an extrinsic factor. But their physiology may be quick enough, agile enough, their muscles may be strong enough and their nerves fast enough to stop them actually falling. Whereas an older person could slip on the ice, but actually the intrinsic factors related to aging have meant that that slip leads to a fall, and therefore there's an interaction between the intrinsic and the extrinsic factors as we get older.
So next in the assessment is examination. So as always, you're going to want to do a fairly thorough examination to try and find out the cause, but also the consequences. So there are some specific things you want to look for in people who have fallen. Remember to assess their neck, their back and their chest for any tenderness that might indicate that they've got either spinal fractures or rib fractures. These can be really quite painful. You want to examine their joints for swelling and redness and effusions. If they have gout, for example, which has caused them to fall over in the first place, you need to target your treatment there, but also thinking about how that's going to affect their ability to wait there going forwards. Have they fallen onto their knee and developed a hemarthrosis? Are there any other joint deformities that might indicate that they have broken a bone somewhere? Large hematomas can be really easily missed because they're usually in hidden areas. So remembering to have a look at the thighs and the buttocks. If it's quite a large hematoma, then quite often that can lead to a significant drop in your hemoglobin as well. So understanding that can mean that you know what's happening with hemoglobin and avoid some other investigations. We want to look for any other joints and spine deformities that might be due to arthritis or due to osteoporosis that might be affecting joint stability, their gait, their posture. So looking for reasons, those intrinsic reasons why someone might have fallen that you might be able to treat or help manage. Looking for sarcopenia, which is muscle wasting. This will decrease a person's ability to right themselves if they lose balance or trip. It's something that we can focus physiotherapy around improving that going forwards.
When doing your cardiovascular examination, check for abnormalities of pulse rate or rhythm, listen for heart murmurs, and check a lying and standing blood pressure if you can. This will give you a better idea about some of the more common cardiac or blood pressure related causes of falls. And it's worth spending a bit of time on the neurological examination, as there are lots of subtle signs which can give you a pretty good idea of why somebody might be falling. So, for example, Parkinsonian signs such as tremor, rigidity, and bradykinesia, abnormalities of gait, balance, or coordination, which might suggest a cerebellar pathology, limb weakness, which could be from a new or previous stroke, for example, and look for sensory deficits, particularly in the feet, because these can make people prone to trip on things. And if you can, do a quick visual assessment, even if it's just visual acuity and brief visual fields.
Some other things might not be immediately obvious. So, for example, inappropriate walking aids or things being the wrong height, inappropriate footwear should definitely be noted and refer on to members of the wider MDT for support in correcting those.
So thinking about investigations, aside from blood tests, look for things like dehydration or anemia or underlying conditions that may predispose someone to falling. Your initial investigations are mostly going to be aimed at ruling out these cardiogenic and neurogenic causes of the falls. Everyone will need a 12-lead ECG, and if there's suspicion of an arrhythmia, you may want to go on and do further tests, such as a 24-hour tape, particularly in those people who've got syncopal symptoms and an abnormal ECG.
Doing an echo as an inpatient is not usually required for people who have fallen, with the exception of a few scenarios. So firstly, if you suspect that they've got severe aortic stenosis that's causing the syncope or the presyncope. For people who you found a low heart rate, so a bradyarrhythmia that may need pacing to correct the cause of their syncope, and this will be guided usually by your cardiology team as to whether that's something that they're going to do, and that will usually happen while they're an inpatient then and there. Also, if you're looking for any other acute pathology that might have affected the reason that they have fallen in the first place. So for example, if they've got new or worsening heart failure, then you might want to do an inpatient echo. Otherwise, that investigation can usually be done as an outpatient.
In terms of neurogenic causes, the first investigation you're thinking about really is a CT head, and you'll want to do that for anybody who's got a head injury, who's on anticoagulation, or who's developed new neurological signs, and this can include seizures. Likewise, for anyone in whom you suspect a brain tumour, an intracranial bleed, or a stroke. And finally, don't forget to check blood glucose early on and during admission if they're diabetic, as it's always a bit embarrassing to miss hypoglycemia.
Yeah, that's the DEFG, isn't it? Don't ever forget glucose. So now what are you going to do with the information that you've gathered? If you think someone's had a seizure, remember to look for an underlying cause. So hyponatremia, alcohol withdrawal, hypoglycemia. If it's a first seizure, many trusts have a first fit clinic that you can refer people into on discharge. If they're already known to have epilepsy, but their seizures are poorly controlled, then you might want to have a chat to the neurology team or one of the physicians about adapting their medications. Either way, if someone's had a seizure, you need to tell them to inform the DVLA And there's good structured guidelines on the DVLA website telling you both how to do this and the certain situations that you need to inform patients about. For people that have got Parkinson's disease or in whom you suspect it, more importantly, in who you suspect it, you can refer them to the Parkinson's team, who may well see them as an inpatient or in the outpatient clinic.
So, as we mentioned, some cardiac abnormalities will require an inpatient review by the cardiology team. And these are usually things like acute coronary syndromes, severe aortic stenosis with collapse, and people who need an urgent pacemaker. Lots of older adults will be taking lots of medications that will increase their risk of falls. So a medication review is really, really important in people who have fallen. We've done a separate mini session on polypharmacy with tips on how to do a medication review in that, so you can check that out. We won't talk about that more. Input from the whole MDT is really, really important when seeing people who have had a fall. So make sure that you communicate regularly with the rest of the team and share updates on the progress on each side. Patients don't necessarily have to be medically fit before the rest of the MDT can get involved, and they can review them and get them up and walking, but they might need some reassurance about whether or not their assessments might provoke further collapse if sympathy was the reason that they fell in the first place. If the cause of the fall is still not clear when you're sending that person home, but they're safe to go home, then you can usually refer them on to a local falls clinic, which is usually run with or by a geriatrician with an MDT, to finish their falls workup as an outpatient.
So that's all for this session, but feel free to check out the rest of this mini-series for more bite-sized learning. Or you can head over to our website at www.thehearingaidpodcasts.org.uk for full-length podcast episodes on a whole range of topics concerning older people, from heart failure to homelessness. We've also done a whole episode, or possibly 2 episodes, concerning falls. And we hope that this episode of Help has been a help. Bye.
Bye.